Hi, everyone. Thanks so much for joining us. I think we'll go ahead and get started, and a few people may continue to join in these first few minutes. So welcome to the Summer Passport Series with the Einaudi Center for International Studies, and to today's event on immigration, healthcare, and the coronavirus crisis. I'm Eleanor Paynter, Postdoctoral Associate with Cornell's Migrations Initiative, and I'm also part of the Einaudi Center's Migrations team, along with today's speakers, Gunisha, Kaur, and Yale-Loehr. Today's event is the final session in the Passport series, and I'd like to start by thanking our Einaudi Center team, including Director Rachel Beatty-Riedel, for putting on these webinars and conversations. And thanks to you all for joining us today, and thanks also, of course, to today's speakers. Gunisha Kaur, I'll introduce them briefly now. Gunisha Kaur is an anesthesiologist specializing in global health and human rights, particularly among displaced populations. She serves as medical director of the Weill Cornell Center for Human Rights and as director of the Anesthesiology Global Health Initiative. And Yale-Loehr is a professor of immigration law practice at Cornell Law School and counsel at Miller-Meyer in Ithaca, New York. He's co-author of Immigration Law and Procedure, the leading treatise on US immigration law, and he works with refugees and with people who are detained. I'll let Steve and Gunisha say more about their own work as we get underway. And I'll begin by noting that the communities and individuals that Steve and Gunisha work with include asylum seekers, refugees, and immigrants whose legal status in the US depends in part on how and why they entered the country, and whose access to care is then affected by those legal questions. And so today we're focusing on some specific medical legal circumstances that asylum seekers, so people who are hoping to obtain protection, refugees who have been granted that protection with refugee status, and immigrants in the US confront as they navigate the present pandemic. And these circumstances and the pandemic more generally reflect the importance of understanding immigrant health as part of the collective public health of the country and the globe. We've also seen how quickly and drastically a pandemic affects people's movements. We've seen how quickly governments closed borders and limited international and domestic travel, and now, perhaps for the first time, those of us with US passports find ourselves unable to enter many other countries. As we consider circumstances in the US, I think it's important to hold in mind that countries have managed borders and immigration status very differently in response to the pandemic. And so before we get into today's presentation in more detail, I'm just going to offer a few examples from other regions by way of context. So in March, for example, Portugal granted temporary citizenship to asylum seekers and other migrants registered with the state to ensure they could and would access care if needed. The Greek government has reopened Greece to tourists, but has extended the lockdown for the tens of thousands of asylum seekers and refugees who live in camps on Greek islands. And these are places where social distancing is really impossible, and there's a scarcity of hygiene and first aid supplies. In Bangladesh, the pandemic and a scarcity of resources and testing has amplified tensions about the forms of care and aid available to locals living in extreme poverty, and also to the 1.1 million Rohingya living in camps there. In South Sudan, where ongoing violence threatens the country's stability, pandemic-related restrictions have limited humanitarian access to the peacekeeping bases that house internally displaced persons. South Africa recently built a fence along its border with Zimbabwe, claiming that this would prevent spread of the coronavirus. And these really quick examples also highlight the ways in which governments have used their pandemic response to manage borders differently and to regulate migrants' legal status and residency in new and sometimes stricter ways. So returning to the US, at least some of the spread of the disease in Central America has been traced to deportations from the US, which has flown COVID-positive migrants to Guatemala, Haiti, and Mexico. And that's also a reminder, I think, that how the US handles legal questions of migration can have an impact on public health, both here and abroad. And with that, I'm going to hand it to Gunisha Kaur and Yale-Loehr, who are working on these issues directly through Weill Cornell College of Medicine, Cornell Law, and in their collaborative research as faculty fellows with the Einaudi Center. And I'll just note here that we've already received a few questions related to today's talk, and we're happy to take more. So as questions arise for you, feel free to type them into the Q&A, and we'll save a little bit of time at the end to address as many of those as we can. And so if you can go to the next slide. So this is just an overview of the topics that will be covered today, from immigrant communities and health disparities to immigration-related executive actions, immigration detention during the COVID-19 pandemic, questions about healthcare concerns and access for immigrants, and then we're going to take some time near the end to talk about what Cornell's Migrations Initiative is doing on this issue.
Thank you so much for the introduction, and we'll launch right into it. So today we're going to talk to you about medical legal issues covering aspects of healthcare with immigrants currently in the context of the pandemic. What we know is that natural disasters, pandemics, acute problems like this reveal natural fault lines in existing infrastructure, whether it's social, economic, political, or healthcare. And that's really what this pandemic is doing. In terms of healthcare disparities, using COVID-19 as a case study, here's what the data are telling us about racial and ethnic disparities. We know that in places where numbers are counted, in geographic locations that are reporting data by ethnicity and by race, African Americans and Latinos are disproportionately impacted by COVID-19. So not only are they more likely to contract the disease, but when they do, the healthcare that they receive is poorer, and that their morbidity and mortality is increased. We've seen this data in Chicago, we've seen it in New York, and where the data do exist in terms of other minority communities, such as Native Americans or Alaska Natives or Pacific Islander communities, they experience the same sort of disproportionate burden of disease. Often the data in those communities is weak because we just don't have the numbers. And that's what we're seeing in immigrant populations, particularly in asylum seekers, where we can presume that the disparities are similar, but we really just don't have the data to demonstrate it. And of course, the underlying causes of healthcare disparities are incredibly complex. They include social and structural determinants of health, racism and discrimination, economic and educational disadvantages, healthcare access and quality, amongst other biosocial factors. There are a couple of explanations that people provide for this disproportionate burden of COVID-19. One is that minority populations carry a disproportionate burden of illness that predisposes them to worse COVID-19. So for example, hypertension, cardiovascular disease, severe asthma, that's more popular, more prevalent in minority groups and minority populations. And so when they are hit with COVID as well, the outcomes tend to be worse. Secondly, minority and impoverished people in urban settings live in more crowded conditions in terms of neighborhood and households, and are more likely to be employed in more public-facing occupations such as service and transportation industries that would prevent them from social distancing. And of course, all of these explanations must be considered in the context of systemic factors such as discrimination and the physiologic insult of chronic stress. There are several things that might play into chronic stress. For example, loss of insurance, loss of housing, loss of food access. The term weathering has been used in medicine to describe aging and real physiologic aging and bodily aging that's caused by wear and tear from fight or flight response, which is just an extreme stress response. And we see that in racial discrimination, but we also see that in terms of these other minority populations where we may not be able to measure it in exactly the same way. So what I'm describing here with racial and ethnic disparities is really parallel to what happens in immigrant communities, even though sometimes we may not be able to access those numbers. There are some data that we have, and when we talk about immigrant communities there are a couple of sets of individuals that fall into that category. So there's legal immigrants, there's refugees, there's asylum seekers, and then there's undocumented immigrants. And we have pockets of data on each of those sets of people. Baseline stress factors and experiences of ethnic and racial minorities, such as policing or lack of housing, food insecurity, those are similar stressors that are experienced by immigrant communities. And within that category, non-legal immigrants, that they're particularly vulnerable. Of all of these vulnerable populations, they're particularly vulnerable. The Affordable Care Act excludes undocumented immigrants from coverage eligibility, which means there's 7.1 million undocumented immigrants that lack health insurance. Many don't have primary care providers. And in this era, most of you have probably noticed, even just from your own personal experience, that primary care providers have become incredibly important. Most immigrants that are undocumented will access healthcare through emergency medical care. So emergency departments, if they have an issue, because they get coverage, healthcare coverage, through going through emergency departments, that's typically the route that they might access healthcare. In a situation like COVID, where there's this massive pandemic and we're telling people not to come to emergency departments for their own safety and for the safety of other patients, that puts this population in a particularly vulnerable position. If they don't have access to an emergency care setting, they really then are blocked from all healthcare access. Other barriers that we talk about for minority communities in terms of English proficiency, for example, or how they might be limited in their ability to access telemedicine, which has really taken off in the COVID context. Those are, again, particularly challenging for people who are undocumented. For example, telemedicine, which, as I described, has really taken off in this context, and most physicians are really encouraging telehealth visits whenever we can. In addition to all of the concerns that an individual from a minority community might have about telemedicine visits, undocumented immigrants are also concerned about potential tracking, fear of government agencies such as ICE. If we look at contact tracing, which has become really popular in this context and is a critical component of our ability to contain COVID, in some states like Massachusetts, that's happening through healthcare providers, where a healthcare organization has taken on that task and that role. But in other places, it's being done by the police. So what is the impact, either psychologically or physiologically, on an undocumented immigrant of policing happening in and not just the typical context in which policing is happening, but also in a healthcare context? And that really layers on top of stress that these communities experience. Shelter at home, which we are all recommending, of course, has enormous impact on undocumented immigrants, many of whom are in service industries such as restaurants, hotels, or in the informal economy. And worst, these communities are really excluded from social safety nets, and particularly when they think they are ineligible for some of the social safety net that Steve will talk about in a little bit, that becomes very straining and very stressful, especially for children who are impacted. When we talk about disease in these communities, how African American communities or Latino communities or undocumented immigrants might be affected by COVID more than other populations, we have to be really careful in how we discuss that. We have to include very rigorous, granular data that really helps describe the problem without making minorities a target. We don't want to reinforce ideas that minorities are the cause of these diseases or are bringing these diseases or are spreading these diseases in other communities. That can lead to problems such as really neglect by society or government, blaming of communities, stigma that results in them disengaging from healthcare systems or providers even further. We really don't want the resultant narrative of COVID-19 to be that it is a problem of minority communities or immigrants or refugees leading to further discrimination. The news has really been keeping up in sort of an impressive way, and it's not completely thorough, but there have been studies that have made it to the news about the disparate impact of COVID-19 in different populations, but they really have not covered so thoroughly what's happening with immigrants. There are, again, many reasons why people don't seek care, or when people do seek care, that it can be extremely delayed to the point where there's nothing that can really be done. And that includes a lack of trust in healthcare or healthcare systems, fear of the cost of care, not just the cost of missing work, but what it might be to not be able to provide for their families for several days if it's, for example, an operation that has to happen for the days that they are hospitalized, cultural and linguistic differences and inability to access English language in a way that makes them feel like they can own their own healthcare, and then a lack of insurance and fear of deportation. With that, Steve is going to speak specifically about public charge rule and immigration-related executive action during the COVID pandemic.
Great, thanks a lot. So this administration has taken the pandemic and run with it in terms of trying to use it to restrict immigration even more than they had since they came into office in January of 2017. They've issued a number of immigration-related executive actions during the pandemic, beginning way back in March, when they decided that because of the pandemic, they were going to stop refugees from coming into the United States. Even before the pandemic, we had a historically low number of refugees who were going to be resettled, only about 18,000 this year. By contrast, in the last year of the Obama administration, they proposed to bring in more than 100,000 refugees. But with this executive order that came about in March, we have decided to not basically admit any refugees except for emergency cases. There's only a few hundred refugees that have come in since March because of this executive order. Then a month later in April, another executive order basically said that we're going to stop green card holders overseas from being able to enter the United States. So if you are trying to get a green card and are already in the United States, you're not affected by this. But if you're overseas waiting to get a green card based on marriage or because of your employer, this executive order prevents you from actually coming to the United States, even though you have the ability to come in because you have an approved green card petition for you. Jumping ahead to June, the President extended that suspension of legal immigration and also then added many temporary work visa categories. So common work visa categories such as the H-1B or the J-1 now are not able to come into the United States because they were sort of tacked on to the suspension of the April executive order. And then going back up to May, the executive branch decided that because of the COVID pandemic, people would not be allowed to come into the United States to apply for asylum. That is under challenge right now, but it is certainly a problem because people who are fleeing persecution no longer are able to apply for asylum and have to wait in Mexico. Let's go to the next slide here. I had mentioned that one executive order affects international workers. And several 100,000 people were affected by this suspension. That is under litigation now, and so far we'll see what the courts rule as to whether that kind of suspension is legal under the US immigration law or US Constitution. Another thing that the administration did was in July, they decided that international students had to take classes in person to be able to stay in the country legally this fall. That was a change from their prior policy. In March, when the pandemic first hit, and many international students went home to their home country. The Immigration and Customs Enforcement said that they could continue their studies using online courses only, and they said that that policy would continue for the duration of the pandemic. But in early July, they switched course and said that if your university, such as Harvard or other universities, were only going to offer online classes this fall, you no longer would be able to be in the United States. Harvard and MIT and several other universities and several attorney generals from various states immediately sued, and a week later a federal court ordered the government to back down. Now, as long as there are at least some options for in-person classes or hybrid classes at a university, international students can be in the United States. But this is another example of how this administration is trying to use the pandemic to restrict legal immigration even more than it had before. Let's go on to the next slide and talk about how the pandemic has affected people in immigration detention. It's been common knowledge that people who are incarcerated, whether they're in regular jails or if they're in civil detention and immigration detention centers, are more likely to suffer COVID because they cannot maintain social distancing. Things like disinfectant are not as prevalent, and they're not being tested as much as people out in the general public. So as of a couple of days ago, over 1,100 detainees nationwide have tested positive for COVID. Also, many people who run the ICE detention centers, the guards, et cetera, have expressed concern about not having enough personal protective gear, hand sanitizer, et cetera. There are over 21,000 people who are detained as immigrants, not because they've necessarily committed any crimes, but simply because they want to be in the United States. And yet we're treating them worse than federal prisons, where many times federal prisons have allowed people to be released for humanitarian reasons because they're likely to get COVID. In the immigration detention context, ICE and the private contractors who run many of the immigration detention centers have refused to release people. I can give you an example from our own Cornell Asylum clinic, where we represent a doctor from Cuba who fled Cuba because of persecution, went to Nicaragua, then walked all the way to the US-Mexico border. She and her husband, who is also a doctor, then immediately applied for asylum. Her husband was able to win asylum-related relief and now is in Florida with a relative waiting for his wife. But his wife, our client, had warned us that the detention center in Arizona where she was detained was likely to have COVID cases. And so we applied for humanitarian release. That was denied. And then she herself contracted COVID-19 in the detention center, had severe symptoms. And again, we applied for humanitarian release, and again, she was denied. So now we've had to sue in federal court to try to get her released from detention. So that's an example of the hard line that Immigration and Customs Enforcement is taking to be able to try to prevent people who should be released from being released. Let's go to the next slide. Another factor that is occurring is that many immigrants are worried about whether they can go to a hospital or get health insurance if they have COVID or are worried about getting COVID. The quick answers to the three questions on the screen are yes, yes, and no. So, for example, immigrants who are subject to health insurance in New York State, for example, can qualify for state Medicare insurance, and they can get health insurance under that plan. Many people had heard about something called a public charge rule that made it harder to get certain public benefits because if you did, you might be deported. But that does not apply to certain instances such as state Medicaid plans in New York State and other states. More recently, for example, a court has held that the whole public charge rule itself is illegal, and at least for the time being, while the case continues to be litigated, that public charge rule is no longer in effect. And so immigrants should not worry about getting health insurance or going to a hospital if you are worried that you might have the coronavirus. So that answers both questions number 1 and number 2. Number three is, you know, if I go to a hospital or a doctor's office, will the Immigration and Customs Enforcement come to nab me and put me into detention? The answer to that is no. Immigration and Customs Enforcement has a policy that they will generally not go to so-called sensitive locations. And those sensitive locations include hospitals and doctors' offices. So even if you are undocumented, you can safely go to a hospital to be treated, not just for the coronavirus, but for any illness, and not worry that you'll be picked up by ICE. Let's go to the next slide and talk a little bit more about this public charge rule. It's become very confusing because of the back and forth litigation that's been going on about this. Historically, in our immigration law, we've always said that if you rely primarily on government benefits to survive in the United States, you might be deportable. But we used to define what constituted primarily dependent as being someone who really only accepted cash assistance. And therefore, relatively few people were actually deportable based on being a public charge. However, in February of 2020, the Immigration Agency came out with a new rule that expanded the concept of what constitutes a public charge to include certain non-cash benefits as well. And they said that if you received one of these bad benefits for more than 12 months within any 36-month period, you might be deportable. It was a very confusing rule because it didn't have a black and white test. It simply said, we'll look at all the facts and circumstances, and on the basis of that totality of the circumstances, decide whether you are deportable. Let's go to the next slide. So as a result, many people were worried that if they accepted any public benefits whatsoever, even going to a doctor or getting maternity benefits, etc., they might become deportable. What you can do if you're a healthcare provider is assure immigrant patients that indeed, both because the litigation has temporarily struck down the rule, and also because many medical visits are not subject to the rule in the first place, even if it gets reinstated, immigrants certainly can and should go and get tested for coronavirus and get other healthcare benefits. Their immigration status will be safe in those circumstances. Let's go to the next slide. The Immigration Agency, known as U.S. Citizenship and Immigration Services, has explicitly said that they will not consider testing, treatment, or preventive care, such as a vaccine that's related to COVID-19, as part of the public charge determination if the public charge rule comes back into effect. So people should not worry that getting treated for the coronavirus will make them possibly deportable. With that, let's go back. And Eleanor, why don't you talk a little bit about how Gunisha and I are part of a larger effort at Cornell called the Migrations Initiative.
Sure, thanks, Steve, and Gunisha for your words here. So we're your slide about the Cornell Migrations Initiative, and we'll also share a couple of links after this talk, connect you with what's going on here. But this is a large community-wide initiative that is supporting all kinds of interdisciplinary work operations. So projects that are thinking really in terms of multi-phase approaches, so thinking about socio-ecological implications of migration, and thinking also in really interdisciplinary terms, as you can see with what Gunisha are doing with their project, which I think I'll invite you to talk about in just a second. And this is a part of Cornell's Global Grand Challenge. I think this is the first Global Grand Challenge been launched. And it's one way that Cornell is creating a network of scholars and groups who are trying to think in new innovative ways about migration globally, and also involves a lot of people who are with different communities in the US and abroad. And so I think if we have time at the end of this webinar, share a short video that represents some more of that work. And it'll be part of a lecture series in the fall, sort of showcasing some of the work that's being done. And Steve and And Gunisha and Deborah Estrin, who you also see here, are on one of these that's working on an initiative for legal medical care and access. But I'll let you all say more about that project.
Sure, why don't we go to the next slide? So as part of the Grand Challenge, several people, including Gunisha and I and Deborah Estrin, have received funding to explore new ways of researching cross-disciplinary issues within migration. So Gunisha and I and Deborah have decided to focus on public benefits and how they're affecting immigrant patients in the United States, particularly starting out at Weill Cornell Medical Center in New York City. So we've devised a survey to ask immigrant patients about their knowledge about what public benefits they currently receive, what they've received in the past, what they think they can receive if the public charge rule is reinstated. And Gunisha and her team of students at Weill Cornell are going to then do a qualitative survey of patients to find out how this is or is not adversely affecting their medical experiences at Weill Cornell. Then we hope to work with Deborah Estrin at Cornell Tech to be able to figure out ways to be able to better explain to immigrant patients what public benefits they do qualify for. And that is sort of what we're doing there. And Gunisha, why don't you talk about how our particular project fits in with the broader aim of the Global Grand Challenge?
Sure. So I think one thing that's really exciting about this project and about the Grand Challenge is that it's bringing together people from different disciplines to layer on solutions. So what I can provide as a physician is limited just to the medical sphere, and adding Steve into that with his law expertise helps us work together and synergistically create something for this population that we're hoping to help that is really greater than what we can each do individually. And then layering on top of that the tech angle of it, which to both Steve and I is totally foreign. You know, it's really great, and it's a way to tackle this problem really in a multidisciplinary space. And that's the goal of the Grand Challenge, and something that hopefully we'll have a chance to show you a video about at the end.
So with that, in addition to our joint research, we're also doing individual things. And so, for example, let me summarize what Cornell Law School is doing about the impact of the COVID-19 pandemic on immigrants. So in addition to my particular research with Gunisha, the law school has been doing a lot in terms of public outreach. In April, we did a webinar for over 1,000 people nationwide on the impact of the new public charge rule that had just gone into effect. And the coronavirus on immigrants. And then we did an updated version of that webinar in late July for several hundred more people. We've also been involved in litigation, trying to show that the administration's effort to restrict asylum because of the coronavirus is a subterfuge and illegal. We presented some public health experts and represented them in an amicus brief in litigation. And we're hoping that the court will rule in our favor on that. I've already talked about our Cornell Asylum Clinic and some of the work we're doing on behalf of immigrants who are detained and how they are being adversely affected by the ICE's refusal to release them from detention. We're doing that both administratively and in federal court. And we're also helping other individuals in other litigation by acting as friend of the brief or amicus briefs to try to show them the adverse impact. We've also published an op-ed calling for the closure of immigration courts while the coronavirus is going forward. And we're also working internationally. My colleague Ian Kissel has started a project called the International Migrants Bill of Rights, and he has partnered with Columbia Mailman and the New School to convene leading experts from around the globe to talk about how migrants around the world should be allowed certain international human rights, including the right to seek treatment during the coronavirus. And that set of principles has been endorsed by over 1,000 experts around the world. Gunisha, why don't you tell us a little bit about other things that you're doing at Weill Cornell?
Sure. So the Weill Cornell Center for Human Rights is a student clinic that is faculty supervised that provides asylum evaluations for folks who are in immigration court proceedings. In the pre-COVID era, we were doing psychiatric evaluations and physical evaluations and creating a forensic medical evaluation and affidavit for their application for asylum. We also we're seeing people from all over the world. This year, the clinic celebrates its 10-year anniversary, and we've, in those 10 years, evaluated nearly 650 asylum seekers, trained almost 1,000 students and 400 professionals, and the students have really seeded 20 other clinics throughout the country that provide this service, and it really is a critical service. Looking at some of the numbers that just demonstrate the impact, if an individual receives a medical legal evaluation, their chance of gaining asylum is about 95% based on our reviews of our cases, and without an evaluation, it's closer to 30%. I think the reason for that is that we're able to translate signs and symptoms of trauma into words that an immigration court or judge may understand. So for example, if somebody is experiencing forgetfulness, that might be seen as a sign of unreliable testimony, but we can translate that in a specific medical context, depending on what other factors are at play, into signs of PTSD or major depression. So we can help an immigration judge understand that these are not signs of an individual who's lying, it's just a sign of an individual who has experienced trauma. So our clinic has evaluated people from about 74 different countries, and we really have seen a global population of children and adults. Beyond the medical evaluations, we are conducting rigorous research involving clinical trials with refugees. And instead of just documenting trauma, our goal is really to create the best set of guidelines that we can and establish a standard of care for this set of patients that come, and really describe what is the best care that we can provide them once they leave their country of origin, once they arrive to a host country. My research, for example, is on chronic pain management in refugee torture survivors. And we're not just documenting that it has occurred, but really focusing on interventions and how we can rehabilitate individuals so that that pain is more manageable and we're able to reintegrate them into society better. In the context of COVID, a lot of that had to pause. A lot of our in-person evaluations were put on hold. We converted our psychiatric evaluations to Zoom evaluations. The physical evaluations were completely put on pause. That's not something that we felt we were able to do virtually. And then we have, all of our research, because it is considered non-urgent or non-emergency research, meaning it wasn't COVID related specifically, a lot of that was put on pause. So for example, we have a study that works to decrease trafficking of young women and girls in Greek refugee camps. And that study we had to put on pause because we just weren't able to justify the risk to our patient population, bringing them into the hospital for extra visits just for research purposes. I think this has been really challenging for those of us that do work with human rights victims, because we understand, like I was describing before, that these are actually the most vulnerable populations at baseline, and COVID is just enhancing that vulnerability. And it's really hard when we look at, for example, the refugee camp in Greece that I was in December, where there's really supposed to be 5,000 people or so, but that camp is holding closer to 40,000 people or 50,000 people. How do you, those people are in open air tents, there's no ground covering, there's no stations to wash hands, people may get a shower once a week at baseline. So how do you incorporate social distancing? How do you incorporate hand hygiene? And are we really just saying that we can't manage this in this population, and so we're just going to give up? And I think that has been very challenging for those of us that do human rights work. These issues are really complicated, and our goal here is to share with you our experiences and really what we've been doing in this era, in this very complicated time.
Yeah, I have this as a question for both of you. Maybe since the slide is up, I'll just go ahead and ask it now. I'm sure there are people on the call who are interested in what they can do, what we can all be doing in terms of advocacy, and also continuing to just stay aware of what's going on and how it's affecting immigrants and refugees. Can you say a little bit more about what you would suggest?
Sure, well, let me start and then Gunisha can add to that. I don't want to give people a sense of there's nothing they can do. There's a lot they can do. So for example, in 2018, when the Trump administration began separating families, the outcry from the public was such that the executive branch had to back off. And so I think that, you know, opposition and concern by the public can make a big difference, even with the coronavirus. So for example, the recent suspensions of green cards that was imposed by the administration in March and April, and then continued and extended in June, mean that many families still are being separated. Children are going to sleep at night crying because they're separated from their parents. Because they can't come to the United States. And that's a different kind of family separation, and maybe not as visibly obvious as the separations we saw in the refugee camps in 2018, but it's still the same. There was a good op-ed in just one of the evangelical newsletters today about how evangelicals should protest this latest family separation crisis. So that's one thing you can do, is just stand up and make yourselves heard, whether it's through an op-ed, whether it's talking to your member of Congress, etc. Similarly, a lot of the changes have come through proposed rules. And even if you're not an expert on immigration law, you can certainly express your concern about further restrictions on asylum seekers or refugees through these rules. You can contact any immigration lawyer and simply find out, you know, where you can submit a comment through the Department of Justice, etc. So that is another way. Similarly, Gunisha and I are working on trying to understand better the public benefits restrictions on immigrants through our migrations research project. And we'd like to get your input both on any restrictions that you have seen or concerns that you have, or ideas on how to better get the information out to immigrants that indeed they are safe if they go to the hospital to get treated for coronavirus or other healthcare concerns. So those are things that you can do there. We also have a page on the Cornell Law School website called Migration and Human Rights. If you just Google Cornell, the links at that site. You can also contribute monetarily. Many immigrants have concerns about being released from detention because they get here to the United States, they don't have any money, and so they cannot be released. There are national bond funds, and if you contribute to a bond fund, they can make sure that immigrants are being able to be released. Gunisha, do you want to add anything from the Weill Cornell side?
Sure. I think it's hard for people to necessarily get into a healthcare center or a medical setting in this context. I think we're being really restrictive on who's able to enter. But one of the things that I think has been really helpful is data collection and documentation. So the more data that we can get that's really high quality about what's happening in these communities, that is invaluable. That documentation, I think, will be used now and also for years going forward. So contributing to the documentation is really helpful. One of the things, the strategies that I think this administration is using that we're seeing is just causing a lot of confusion about what is allowed and what is not allowed. And I think when people are, when their lives are at stake and they're being extremely cautious about tipping into using a public benefit that might be risky or accessing healthcare that may later get them in trouble, even if the rule says they can, if currently USCIS says that you can access, COVID treatment or COVID diagnostic testing, because the rules from this administration are changing so frequently and without any rhyme or reason, I think that places an extreme burden on this population to be conservative. They end up being conservative because there's just so much confusion that's caused. So I think one of the things that we can do is help spread information to individuals that we're working with about not just what the rules are, but who to connect to for reliable information. And so Steve and I are both resources there, and the law school is, and the Center for Human Rights is as well.
And with that, let me, apparently you all lost me for a couple of seconds and people asked whether I could repeat some of the information I gave. If you Google Cornell Migration Human Rights, that'll take you to our Cornell Law School program on migration and human rights. And there we have a link to various volunteer organizations that you can get more information about and also help either whether it's helping an immigrant or helping them learn English, or contributing to a bond fund to allow immigrants who currently are detained to be released if they pay a bond. With that, Eleanor, why don't we turn it over to you and you can talk about contacts and any Q&A. And if people do have questions, feel free to type them into the Q&A box.
Yeah, type them there and we will take as we can. We've already gotten a few, so I'm going to start with a question that is connecting what I had with something that somebody wrote into the Q&A. You mentioned some of the differences, contextual differences affecting people within the United States. And I wondered if you could say a little bit more about how the pandemic is affecting differently immigrants and refugees differently in a place like New York City, for example, versus we had about undocumented migrant workers in meatpacking industries or farm workers. Could you talk a little bit about different responses in those contexts?
Gunisha, do you want to start with the urban area and I'll talk about rural areas?
Sure. I think urban areas, there's so much disparity that already exists at baseline. And like I said in the beginning, that a pandemic or a natural disaster will enhance that disparity and really worsen it in a way that complicates the situation further. So for example, we know that poor communities, a disease like tuberculosis spreads more widely and has greater mortality in poor communities. And we see this, you know, our hospital is based on the Upper East Side of Manhattan. So we're seeing some of the wealthier parts of New York City and patients in New York City, but just a few blocks up, there's a lot of poverty, or across the park, there's a lot of poverty. And those communities are hit harder at baseline by diseases like tuberculosis or anemia, for example. And what's happening here is that that's just worsening with the loss of the financial insecurity that's coming, loss of housing, lack of trust in the system. Each of those areas is an area of weakness that existed before, but that's really being amplified in the current context. So I think whatever disparities existed before, we're just seeing the worst of it come out right now.
And the same is true in the rural areas. For example, the administration has declared that people working at processing plants like meatpacking or chicken plants are essential, and therefore they have to continue working. Many of them feel that even if they weren't declared essential, they would need to continue working because they couldn't support their families otherwise. But many of these meatpacking plants and chicken processing plants do not, or claim that they cannot maintain social distancing because they need to get the meat and the chicken out so fast. And so many of them have been exposed to coronavirus, and at least some of those plants have had to be shut down temporarily because of those concerns. In terms of other efforts to help people in rural areas, Cornell has a very good farm worker program, and they have done a lot. So for example, they have put out videos and FAQs about the coronavirus in Spanish and MEM and other indigenous languages. They've also sent text messages in Spanish on how you can protect yourselves if you're working on a farm, for example, in upstate New York. They've done Q&A sessions with doctors in Spanish about, how they can protect themselves in the coronavirus. They've distributed over 7,500 cloth face coverings to farm workers. They've organized emergency food drops because it becomes more difficult than normal for many farm workers to get off the farm to get into a grocery store. And while they were not able to hold live legal clinics to explore their legal options, they have organized 6 virtual legal clinics to allow people to hook up with law students to try to understand what legal rights they may have. So, it's sort of catch as catch can. We're fortunate at Cornell that we've got a farm worker clinic here who can do all that. But in other parts of the country, many rural migrants, whether legal or illegal, have to worry about going to work and catching coronavirus because they don't have any other options.
I think one of the question was about what do we know about these populations, and unfortunately, I think again the data are really lacking here. It's really hard to collect data, especially in populations where there's a fear of tracking, and so that makes it very challenging for us to collect data. There's also this interplay in factors that is making the situation that sort of like we've talked about before, but I'll give an example that I think really highlights how problematic all of these issues can be when they're combined together. So if there's a student, let's say, who's supposed to be doing virtual learning in their high school, for example, but instead of doing that virtual learning, that individual who has been contributing to their household income in a critical way by being an Uber driver or a food delivery service provider. In this pandemic, the need for those types of individuals, those essential workers, has increased exponentially. And that individual, because they're so critical to their family income, may not have the option of participating in school. So that's a very complex interplay that has come up because of this virus. But what is the multi-generational impact of that? A student who may have otherwise graduated high school and contributed back to their family and their family income and elevated their family's financial status, who now is being forced into a working situation, a dangerous working situation, and is potentially bringing the virus back to their family. So a lot of the weak support systems that we have for those kinds of students and individuals has really fallen apart.
We also have a question here about how care is available to newly released asylum seekers. I'm not sure if this means people who are released from detention or people who have perhaps been granted refugee status. And I'm going to put these together. Any other information about additional to people who are in detention and how ICE has responded to advocacy and litigation related to COVID and detention settings.
Well, like Gunisha started about talking about newly released asylum seekers, then I can go on more about detention.
Newly released asylum seekers, at our clinic, we plug them into, well, anybody who is even seeking asylum, we plug them into healthcare at our clinics, at our free clinics here. So in terms of healthcare, they can receive free care, but also we try to plug people into housing services and English language lessons and plugging them into childcare so that they can get better work opportunities. So we do try to do a lot of that. What I would say is that often I think people are entirely overwhelmed by the totality of their circumstances. So if they don't have housing, they don't have childcare, they're trying to get a work permit, they're trying to get insurance. And a lot of the very long-term care sorts of things like primary care, if you need to do cancer screenings, those kinds of things, blood pressure management, it ends up being put to the back burner. And that really contributes to some of what the term weathering, you know, chronic wear and tear on an individual's body because they haven't been able to fully address their healthcare needs and their psychological needs and their mental health needs. So we do provide services, but I find that people may not use them because they are just overwhelmed.
In terms of detention, Immigration and Customs Enforcement has taken a very aggressive stance, refusing to release people from detention. That's why we had to sue in federal court. There have been a number of cases around the country where people have had to sue to get released, and depending on the medical condition of the detainee and how long they've been detained, some of those have been successful. But it's been very frustrating that ICE refuses to acknowledge the increased risk of contracting COVID-19 in these immigration detention centers. Eleanor, back to you.
Thanks. We have just a couple of minutes left. And so I wanted to close by asking you to think a little bit about looking forward into the future. So I wonder if it sounds like for a lot of people, this is a sustained limbo period in this moment, which is especially hard in a health crisis. I wonder if you have any thoughts about what might happen, what might change, not change, as we come out of the pandemic, if I can frame it optimistically. What are going to be the lasting impacts of these legislative changes for people, and what might be the situation for people whose cases have now been sitting in a court a long time, for example?
Well, on the immigration legal side, it's hard to say. Even if we were able to get over coronavirus, there have been so many restrictions on immigrants generally, it's going to be hard to overturn even if we get a new president and administration. We also need to see what the courts are going to do. If the courts decide to eventually reinstate the public charge rule, then many immigrants will worry about accessing any public benefits, even though even under the new rule, they are entitled to some benefits. So I think it's going to be a long, hard slog for immigrants the next few years. Gunisha?
I think it's going to be a long process of change for all of us. I think medicine has experienced a kind of insult that nobody could have anticipated, that we really are barely getting through at the best of times. And I think you know, it's causing a lot of shifts in the way that we do our work in general. I can't even predict what the future looks like for asylum seekers in our system. You know, I think a lot of the fear that has been caused by the public charge rule, whether it sees you know, the light of day or not, is lasting damage. Once you have millions of immigrants that are disenrolling because of fear of a rule, I don't anticipate that going away. I think that has caused lasting damage in these communities. And so we will have to work very hard to build up that trust again. And like any situation, once trust is broken, I don't know that we can actually come back to where we were.
Thanks to you both. It marks 2 o'clock for us, so I'm gonna end our conversation on this note, thinking towards the future. And I think you've given us so much to think about, and words of caution and concern here at the end too. And so we'll be sharing with you an email for those of you on the call and others signed up, where we'll include some links to some resources and some of the things that we've mentioned, one of the articles that you saw posted, and we'll also include a little bit of information on what's coming up with the Einaudi Center and the other talks by in the Migrations Initiative that you will be invited to join in the fall. With that, I thank you, and we'll be in touch. Thanks.